So today we will talk about the large intestine. So large intestine, it extends from the ileocecal junction to the anus. It will extend from ileocecal junction to the anus, and its length is 1.5 centimeter. Its length is 1.5 centimeter. Regarding the function of the large intestine, absorption of the water and the minerals, it lubricates the feces by secreting the mucus, storage and expulsion of the feces, and synthesis of vitamin B with the help of bacterial flora, and protection of the microorganism by secretion of the IgA antibodies. So these are the functions of the large intestine: absorption of water and the minerals, secretion of the mucus, lubricants, storage and expulsion of the feces, synthesis of vitamin B with the help of bacterial flora, and protection from the microorganism. The parts of the large intestines are the cecum, appendix, colon. We draw this diagram. Actually, the cecum starts from where? From the ileocecal junction. This is ileocecal junction. This is appendix. And so this portion is the cecum. This portion is the cecum. We have got ascending colon over here. Then we have got the transverse colon over here. Then we have got descending colon over here. We have got the sigmoid colon, then rectum, and finally the anus. So the cecum, appendix, and the colon. Colon is standing from the ascending colon, then transverse, and then descending. All three into the colon: ascending, transverse, and descending. So ascending colon, transverse colon, and we have got the sigmoid colon also, rectum, and the anal. These are the parts of the large intestine. Over here, this is the appendix over here. So this one is the ascending colon. The sigmoid, the cecum has not been shown over here because the cecum, if here we have put ileum, this could be the cecum. Then we have got ascending colon over here. This is the transverse colon, descending colon, sigmoid colon, and the rectum over here, and we continue with the anus. Biologically, the parts of the large intestine which develop from the midguts are the cecum and the appendix, ascending colon, and right 2/3 of the transverse colon. The midgut derivatives are supplied by the superior mesenteric artery, and the hindgut derivatives are supplied by the inferior mesenteric artery. Then what are the portions which develop from the hindguts? They are the distal 1/3 of the transverse colon, descending colon, rectum, and upper portion of the anal canal. About the ileum over here, where the appendix, the sigmoid colon, then we have rectum, and finally anus. This much portion developed from the midgut. And here we have got the portion of the hindgut. So hindgut portions are the lateral 1/3 of the transverse colon, lateral 1/3. Then we have got the descending colon. Then we have got the sigmoid colon. Then we have got the rectum, and we have got the anus. So these are the portions which develop from the hindgut. The terminal part of the hindgut, all the derivatives are from the endoderm. They develop from they are endodermal derivatives. The terminal end of the hindgut is the endodermal lined pouch termed as cloaca. We have got this sort of arrangement, and this is called the cloaca. But this cloaca is not seen in cases of the human being because this has been partitioned. It has been partitioned into two compartments One is for the urine, other is for the urinary bladder. Here we have got, and where we have got the rectum over here. So it has been divided into two parts by the urorectal septum. Urorectal septum divides this cloaca into two compartments, and we have got the rectum and the anal canal and the urogenital sinuses. Urogenital septum divides into the urinary. This is the urorectal septum. We have got the rectum over here. Then we have got the anal canal. First we have got the rectum, then we have got the anal canal over here. And the urogenital sinus. Urogenital sinus. The important is the rectum and the anus over here. Distal end of the anal canal arises from the canalization of the ectoderm. We have got the rectum over here and the anal canal over here. Rectum, and we have got the anal canal over here. Distal part, this portion of the anal canal, will develop from the ectoderm. They are the ectodermal derivative. So we have got the endodermal derivative up to rectum and the anal canal half portion. Anal canal half portion, we have got this much portion, which is rectum, which is anal canal, and this portion we have got above that or everything, we have got endodermal derivative. And here we have got the ectodermal derivative. So this partition between the endoderm and the ectoderm, this is known as the pectinate or the dentate line. This has been marked by the pectinate or the dentate line, and which is actually the demarcation between we have got the rectum, then we have got the anal canal. This anal canal, in the halfway, it is being marked by the pectinate line. Which is nothing but this is the endodermal derivative, this is ectodermal derivative. So the division, the partition between the endoderm and the ectoderm, this is known as the pectinate line. Now we have got the unique feature of the large intestine, and the unique feature of the large intestine is the tinea coli, the hostration or the circulation, and appendices epiploica. So we have got the tinea coli over here, we have got the hostra over here, and we have got the epiploia appendices over here. We will see it one by one. So tinea coli, they are the three ribbon-like bands of the longitudinal muscles, layer of the muscular externum of the colon. Over here, these are the tinea coli. Actually, we have got the circular layer inside, and we have got a longitudinal layer outside. This longitudinal layer in the large intestine, at some point, this is the longitudinal layer. At some point, it get concentrated over here. At some point, it will get concentrated. And this large intestine, after getting concentrated at some point, 1, 2, 3 points, in the remaining portion, this longitudinal muscle, this is actually the longitudinal muscle. We are talking about the longitudinal muscle. Inside we have got a circular muscle. So this is the band of the circular muscle, the longitudinal muscle. The longitudinal muscle outside, it will get concentrated at some point, and at the remaining point, it will become thin. So it is a muscular band of the longitudinal muscle also, or only we have got the appendices epiploia. These are the small bag of peritoneum. You could see over here. We will see further also. This is the small bag of peritoneum filled with the fat, and they are secreted all over the surface of large intestine, but it will not seen over the appendix, cecum, and the rectum. This is not seen over the cecum, appendix, and the rectum. Then finally, we have got the circulation or the hostration. They are series of dilatation of the cecum and the colon. They are actually produced by the, since the large intestine, the length of the circular layer is 1/6 time more than the longitudinal muscles outside. So the longitudinal muscle will cause the circular muscle will become shorter in length to accommodate the longitudinal muscle. So what happens? These are produced by because of shorter length of the tinea coli than the circular muscle. It gives puckered appearance of the large intestine. We will see later. Yeah, this one is the this is the hostration. These are the hostration or the circulation. The peculiar feature of the large intestine is the, now we come to tinea coli. Now the tinea coli, longitudinal muscle coat of the region we have already seen, and the remaining part we will see only the thin layer of the tinea coli. Remaining part we will see only the thin part of the tinea coli. They are the three ribbons like structure, like band, and they are known as the tinea coli. Proximally, the tinea coli converges at the base of the appendix, and distally they spread out at the terminal part of the colon. So this is the appendix. This is the appendix. See this one here. We have got the appendix over here, and this actually is, this tinea coli is concentrated over here. It starts from here, and finally we have got a rectum over here, and it ends at the rectum. It ends at the rectum. Below the rectum, we will see only the longitudinal muscle only. We will see the longitudinal muscle only. So it begins at the appendix. It begins at the appendix, and it ends at the level of the rectum. Below the rectum, we will not see there. Below the rectum, it will continue as the longitudinal muscle cord. Now the tinea coli has been named according to their attachment to the transverse colon. Actually, this tinea coli, we have got the ascending colon, we have got the descending transverse colon, and we have got descending colon. The tinea coli will be seen all around. It will be seen all around, but its attachment to the transverse colon, where it is attached on the transverse colon, this will give it name as the tinea mesocolica, tinea omenthalis, and tinea libra. So we have got the three types of tinea coli. One is the tinea mesocolica, one is tinea omenthalis, one is tinea libra. We know that we have got the large transverse colon, and transverse colon is having the mesentery. Transverse colon is having the mesentery, and this mesentery, take the stomach over, is the liver over here. We have got the stomach over here, and we have got the stomach over here, liver, and the colon over here. First layer will come like this. It will come like this. Like this. It will go like this. It comes like this. This is the omentum, greater omentum. It is actually going like this. It will come like this. So, and we have got the remaining layer, that is the third layer will come like this, and it will go like, it will complete like this. This layer, actually this forms the transverse mesocolon. This forms the transverse mesocolon. This forms the transverse mesocolon, and here we have got the pancreas. We have got the pancreas over here. We have got the pancreas over here. This is the pancreas. The transverse mesocolon is attached to the posterior part of the transverse colon, and the body and the apex of the pancreas. What do you just like this? So if this is anterior, and this is posterior. So it is attached on the posterior aspect of the transverse colon, and up to the pancreas. We see over the pancreas over here. It go up to the pancreas. This much area is the area of the transverse mesocolon. It will go like this. Posteriorly, we will see the transverse mesocolon, and there we will see the transverse mesocolica. Then we have got omentalis. We know the omentum is coming like this. This omentum is coming like this. So we have got the anteriorly attached. So we have got tinea omentalis over here, and tinea libra. We will not find any sort of attachment on the tinea libra. So this diagram we could see over here. Now the tinea mesocolica. How tinea mesocolica is being placed? So it is placed. We have just read that it is placed posteriorly on the transverse colon at the site of attachment of the transverse mesocolon. Yeah, on the posterior surface. So this is the posterior surface. This is the posterior surface of the. This is the posterior surface of the transverse. This is the posterior surface of the transverse colon. So it is attached on the posterior surface, and it is posteromedial. It's attached to the posteromedial, and you could the posteromedial is the posteromedial part of the remaining part. So on the remaining part, it's posteromedial on the surface of cecum, the ascending colon, and the descending colon. And the remaining part, it will be on the same thing, the same tinea, which is on the posterior surface of the transverse colon. It is coming on to the posteromedial surface of the ascending colon, the cecum, and the descending colon. Then we have got the tinea omentalis. This tinea omentalis, as the name suggests, we have already read about that it is placed on the anterosuperior surface of the, because omentum is on the anterior surface, and omentum is situated where? Omentum is on the anterior surface of the transverse colon. So we have got this is situated anteriorly. And what about this on the remaining part in the cecum, ascending, descending colon? It will be posterolateral. And so we could see over here, this is the anterior one, this is the anterosuperior, this is the anterosuperior, and where it is going, it is coming posterolaterally over here. So it is coming like posterolaterally in the remaining part. So it will become, so it is the same thing, but it is the change in the position, and the change in position we considered with the transverse colon only. We do not consider the remaining part of the colon. So when it is attached posteriorly into the transverse colon, it becomes posteromedial, and when it attached anteriorly, it becomes the posterolateral in the remaining part. Then we have got the tinea libra. Finally, we have got tinea libra, and this tinea libra is attached inferiorly on the transverse colon. It is attached on the inferiorly on the transverse colon, and it attached anteriorly to the cecum, ascending colon, and descending colon. So we could see this is the inferior surface of the transverse colon, and it is coming like this on the anterior surface of the transverse colon. So it is coming on the anterior surface of the remaining part of the colon. So placed inferiorly on the transverse colon, but in the remaining portion you could see it anteriorly, and this is how the tinea libra is being placed. Now we come to the circulation. So tinea are 1/6 shorter than the circular muscle coat of the colon. We have got circular muscle over here, and we have got the longitudinal muscle over here. So longitudinal muscle is longer than the circular muscle, and this is responsible for pocket of the colon. This is known as the circulation or the haustra. See the haustra over here. This is the haustra. This is the haustra. They are all the haustra. This is all the haustra which is being produced due to the shorter length of the circular layer. Then next we have got the epiploidy appendices. They are nothing but they are the small bag of peritoneum filled with the fat. They are the bag of the peritoneum. This is bag of the peritoneum, and this is filled with the fat. This is filled with the fat, but they are scattered over the surface of the colonic serosa. They contain the important is they contain the vascular stock. Means if this is the appendices over here, so it will have the vascular structure over here. It will contain the vascular structure, and they are most numerous on the sigmoid colon and the posterior surface of the transverse colon. So transverse colon and the sigmoid colon, they are most numerous and absent from the appendix, the cecum, and the rectum. Since it contains the vascular stock, so care must be taken while pulling up these appendices, otherwise there will be huge bleeding because this contains the blood vessels. Now the large intestine is wider in caliber than the small intestine. So this is the caliber of the large intestine. It is larger than and this caliber is greatest at the commencement and gradually diminishes toward the rectum, where it forms rectal ampulla just above the anal canal. So this is maximum at the cecum, and the greater part of the large intestine is fixed by the mesentery, and the appendix, the transverse colon. But the greater part of the large intestine is fixed because they are not peritoneal structure, but the appendix, the transverse colon, and sigmoid colon, they are peritoneal structure. So they are intraperitoneal structure. So they are mobile. The mobile structure, it has to be in the peritoneum. Now coming to the blood supply of the colon, it is very important. It is the marginal artery which supply the large intestine. But how this marginal artery is being formed? This marginal artery is being formed by, we already know that the hind gut is and the mid gut is responsible for forming the large intestine. So mid gut, we know the superior mesenteric artery, and hind gut we have got the inferior mesenteric artery. We already know about that, and both of them are the branches of the aorta. So we have got the superior mesenteric artery. This is the superior mesenteric artery. Superior mesenteric artery over here. This one is the superior mesenteric artery. This is superior mesenteric artery, and we have got the inferior mesenteric artery over here. We have got the inferior mesenteric artery over here. So the superior mesenteric artery and inferior mesenteric artery, they will approach toward the large intestine, and they form the anastomosis. And this anastomosis creates the marginal artery. We have the marginal artery over here. This is the marginal artery. This is the marginal artery. This creates the marginal artery. This will create the marginal artery. This creates the marginal artery. So the marginal artery is formed by the union of the superior branches of the superior and the inferior mesenteric artery. So they are the colic branches. They are the colic branches. Left colic artery. We have got the right colic artery. So right colic artery and the left colic artery coming out from the superior and inferior mesenteric artery, they will form the anastomosis, and the marginal artery in form of marginal artery, and from this marginal artery the branches will go. So the branches from the marginal artery are distributed to the intestine along the long and short vessels as vasa longa and vasa brevia. Longa is the larger artery. The larger artery will be known as the longa, and the smaller will be known as the brevia. So it is the superior mesenteric artery and inferior mesenteric artery, the branches of the descending aorta, and this aorta, this superior mesenteric artery, inferior artery, they form the right colic artery and the left colic artery. This is their right and left colic artery anastomosis to form the marginal artery, and the marginal artery ultimately supply the large intestine. Now the long artery divides into the anterior and posterior branch close to the mesocolica tinea. If we take, this is the colon, this section of the colon. The artery over here divides into the long and the short branches. The anterior and posterior branches. The anterior and the posterior branches. This will divide into the anterior and the posterior branches. at the level of the tinea major-colica. From the major, they pass toward the serous and the mucous port to reach the A major-colic area, that is the tinea aumentalis and then tinea libra. So in this section, if you could see over here, we have got the tinea major-colica over here. We have got the tinea aumentalis over here, tinea aumentalis over here. If this is posterior one, this is anterior one. And finally, we have got the tinea libra over here. Okay. They are the three layers. Tinea aumentalis over here. Tinea aumentalis over here. Tinea major-colica, tinea aumentalis, and tinea libra over here. Tinea libra. This is the tinea libra. This is the one section. This is the section of the colon. This is the transverse section of the colon. Now, the artery is coming over here. Tinea major-colica. And from the major-colica, it will reach towards the aumentalis and it will reach toward the libra. And this artery, which is going toward this is the A major-colic area. This is the major-colic, this is the A major-colic area. But this portion between the aumentalis and the colica, this will be divided of the blood supply. So artery pierces the muscular cord and reaches the submucosal layer. This will go to the submucosal layer. The anastomosis between the two major-colic tinea is extremely poor. Between these two layers, this and this, the anastomosis is very poor. Between this and this, the anastomosis is very poor. So we could take the incision is being taken over here. From the tinea major-colica, it is coming toward the aumentalis and it is going toward the tinea libra. But between the tinea aumentalis and the libra, we have got the very poor anastomosis. So the shorter branches arises from the marginal artery and from the long branches also. Shorter artery will arise from them. We have got the marginal artery over here. So the marginal artery will also give these short branches which is coming from the marginal artery. So the majority of them sink into the bowel wall at the major-colic border. So we have got, if this is the artery is being coming over here. This is the major-colic area. This is the major-colic area. This is the long artery which is coming over here. And the short artery is also coming over here. Short artery is also coming over here. So either from the marginal artery, from the long, the majority of them sink into the bowel wall at the major-colic border. They will sink at the major. So the short and the long branches together provide the major-colic region with the abundant blood supply. So both the short branches and the long branches will provide the abundant blood supply. It is only the A major-colic area which has got the scanty blood supply. But at the level of A major-colic, this is all going posteriorly. This is all going posteriorly. And from here, the branches will go to the remaining part of the remaining colic area. So it is the A major-colic area where we have got the scanty blood supply. Now, the subserous port of the long branches is intimately related to the appendices epiploica. As we have already seen that it is the appendices epiploica is nothing but it is the collection of the fat in the peritoneum, and it is seen mostly on the transverse colon and the sigmoid colon. But it also contains the arteries. The long artery will enter over here. So the bowel wall, if this, take this one, artery is going like this. This is bowel wall over here. And the artery will push over here. Artery will push over here. What will happen? There will be a pouching over here. And we have got the peritoneum over here with the aumentalis. And this outpouching The ball will weaken and will be pierced by the vessels and the site of attachment of the appendix effluvia, and the mucosa may herniate in this situation, and this creates the diverticulosis, fibrosis, or the stricture. So this outpoaching will create the diverticulum. They create the diverticulum. Now the venous drainage. Venous drainage, it is the, as the name suggests, as we know that it is the vein for the artery, so the superior mesenteric artery and inferior mesenteric artery. So with the vein we will get the superior mesenteric vein and the inferior mesenteric vein. But the important is that the superior mesenteric vein will drain into the right, will drain from the right colon and transverse colon, along with the vein draining the small intestine midgut also. Superior mesenteric artery will take the reason from the gut region, that is the cecum, the ascending colon, the 2/3 of the transverse colon, and it will also take the branches from the small intestine. And this superior mesenteric artery join the splenic artery to form the portal vein. This will join the portal artery to form the portal vein. Inferior mesenteric artery is the continuation of the superior rectal vein. See, this is the superior rectal vein. The superior, and this continue as the inferior mesenteric vein. This continue as the inferior mesenteric vein, and it will drain from the blood from the portion of the large intestine which develop from the hindgut. That is the 1/3 lateral 1/3 of the transverse colon, then descending colon, sigmoid, and of course the rectum. But we have got the superior rectal artery over here. This is superior rectal vein over here, and this superior rectal vein will continue as the inferior mesenteric vein. And inferior mesenteric vein is under the body of the pancreas to drain into the splenic vein. We have got the pancreas over here, so it will drain into the splenic vein. It is draining into the splenic vein. This mesenteric draining into the inferior mesenteric vein. Now we have got the lymphatics. These lymphatics have been divided into 4 sets of them. There are 4 sets of lymphatic. One is the epiploic lymph node lying on the wall of the gut. We have got the epiploic. See this lymph node, they are lying on the wall of the gut. Then we have got the paracolic lymph node. They are on the inner side of the colon. Inner side of the colon and adjacent arterial incavity. We have got the paracolic. We have got this is the inner side, and along the vessel, the paracolic one. Only the intermediate one node, they are the main branches along the main vessels. They are the intermediate along the main vessels. You see the main vessels along the main vessels, and then the terminal node at the junction of, this is the terminal node at the junction of the division of the superior and the inferior mesenteric vessels. Where the superior and inferior mesenteric vessels terminate, here we have got the terminal nodes. So in the carcinoma, when it is related to the paracolic and the intermediate lymph node, you know the paracolic is where onto the inner side of the colon along the vessels, and it is the intermediate node which is along the vessels. So we have to remove. You cannot remove the lymph node as such. So we have to remove the blood vessels also. So only after the ligature of the main branches of superior and inferior mesenteric artery along which the lymph node is lying. Where the lymph node lies, we have to ligate that vessels. So it is necessary to remove the large segment of bowel, which otherwise this will cause the necrosis of that portion of the bowel. So while ligating the blood vessels, which will help us to remove the lymph node, at that point we should sacrifice that much portion of the bowel which is being supplied by that portion of the blood vessels. Now we have got finally the nerve supply. Again, it is divided into those portions of the large intestine which is from the midgut and one is from the hindgut. So the midgut territory receives from the celiac and the superior mesenteric ganglion, which develop from the T11 to L1. This is about the sympathetic one, and the parasympathetic will be from the vagus nerve. The hindgut will develop from the lumbar sympathetic, that is the L1 and L2, and the parasympathetic from the nervy irrigants, that is from the sacral nerve. So see over here, this is the sacral nerve, parasympathetic one. This is the thoracolumbar segment. This one is the coming like this, and this is the T11 to L1, and this is the this much is the TL1 to L2. So they are the sympathetic chains, and this is that they are the parasympathetic chain. We have got the vagus nerve, of course, over here, and vagus nerve take care of the midgut region. Vagus nerve will take care of the midgut region. Now, finally, coming to the difference between the large intestine and the small intestine, we know the three important things will be absent in the small intestine. That is the tinea coli, ostration, and the appendices epiploia. This is the most important difference between the small intestine and the large intestine. That tinea coli, ostration, and appendices epiploia, they are absent. Regarding the mobility, this mobile except the duodenum. Duodenum, small intestine is mobile because it is the peritoneal structure. Except the duodenum, first 2.5 centimeter, the remaining portion of the duodenum is retroperitoneal, so it is fixed except for the appendix, transverse, and sigmoid colon. And here also in the large intestine, the greater portion of the large intestine is retroperitoneal, so they are fixed. It is only the appendix, transverse colon, and the sigmoid colon, which is the intraperitoneal structure, so they are the mobile one. Regarding the villi, these are present and absent. Trachea circularis, this is permanent, this is temporary. Paired patches, this is again important thing. This paired patches is the cardinal feature of the small intestine, and it is not present in the large intestine. Goblet cells are few. Here we get the most of the goblet cells. The small intestine is the commonest site for the intestinal worm, typhoid, and the tuberculosis, where a large intestine is common for the amoeba histolytica and the carcinoma. Finally, the histology of the large intestine. So, four layer: the mucosa, the submucosa, muscularis externa, and the serosa layer. We will see the four layers. This is the muscularis externa. This one, tinea coli, outer side. This is the submucosa over here. This is the muscularis mucosa over here. This is the lamina propria over here. And this is the simple columnar epithelium, that is the goblet cells. So mucosa will be the simple columnar epithelium with the numerous tubular cells, simple tubular gland, lamina propria, so discrete lymph node, and muscularis mucosa. Submucosa, connective tissue, no Brunner's gland, and the no paired patches. Muscularis externa, a smooth muscle layer, inner circular, outer longitudinal, and three bands of the tinea coli. And serosa admit a connective tissue layer, partly covered with the mesothelium. Colon do not have the plica circularis, villi, and the penthes cells. So this is all about the large intestine. Thank you.